Bulimia nervosa and the effectiveness of its main form of treatment for adults, extended cognitive behavioral therapy for bulimia nervosa. The main aims of this presentation are to present an overview of the current knowledge about bulimia nervosa and to critically evaluate the effectiveness of the most endorsed form of treatment for bulimia nervosa in adults, extended cognitive behavioral therapy for bulimia nervosa. First, this presentation will provide a brief depiction of bulimia nervosa, its predisposing, precipitating and perpetuating factors. Second, it will summarize how knowledge about the psychological and cognitive basis of bulimia nervosa relates to cognitive behavioral therapy and how effective this type of treatment has been proven to be. Finally, it will identify areas of future research regarding potential independent or add-on techniques for treatment of bulimia nervosa. Symptoms, categories and prevalence. Bulimia nervosa is a severe mental disorder whose diagnostic symptoms are at least one binge eating episode per week. A binge eating episode is defined as consumption of an objectively large quantity of food during a 2-hour period, which is characterized by sense of loss of control over eating. A second symptom of bulimia nervosa is engaging in compensatory behaviors at least once weekly in an attempt to avoid weight gain. A third symptom of bulimia nervosa refers to the fact that these binging and compensatory episodes have occurred for at least 3 months, and finally, one perceives his or her self-worth of being largely determined by his or her shape and weight. And this is according to the American Psychiatric Association 2013. The binging compensatory episodes normally occur in secret. Depending on the main type of compensatory behavior used, 2 subtypes of the illness have been proposed. The purging subtype, where bulimia nervosa sufferers use vomiting, laxative, and for example diuretics, and the non-purging subtype, where bulimia nervosa sufferers use fasting or exercise in order to regulate their weight. Approximately 80 to 90% of the bulimia nervosa sufferers vomit, and approximately 30% use excessive laxatives. Bulimia nervosa occurs in 1.5% of women and 0.5% of men in their lifetime, and the mean duration of a bulimia nervosa episode is 8.3 years. The etiology of bulimia nervosa. There are numerous theories about the etiology of bulimia nervosa, but no consensus exists. A more accurate explanation for the onset and maintenance of bulimia nervosa is most likely to result from considering the complex interactions between predisposing, precipitating and perpetuating factors. This view has received scientific support. Predisposing factors. In order for an individual to develop bulimia nervosa, one must be vulnerable to the disorder. One's vulnerability results from genetic predisposition and from the interaction between genes and environment, that is, facilitation of gene expression for environment. Bulimia nervosa has a strong genetic influence. For example, significant genetic influences between 59 and 82% on bulimia nervosa related features have been found in an adoption study with biological female sibling pairs. These bulimia nervosa features were, for example, eating pathology, binge eating, body dissatisfaction, and weight preoccupation. The research continues to seek candidate genes involved in the development of the disorder, carriers of genotype with serotonin, which presents short alleles on the gene-linked polymorphic region as allele 5-HTT-LPR, have been proposed to present elevated risk of development of bulimia nervosa. For example, of the adult girls who at age 15 reported a history of frequent adverse life events, only those who were carriers of genotype with serotonin which presented short alleles 5-HTT-LPR have had high bulimia nervosa symptoms at age 18. Predisposing precipitating factors. Early life stressors have been shown to impact gene expression through modifications in brain structures, brain circuits, and function of biochemicals. These modifications facilitate some of the symptoms encountered in bulimia nervosa, for example, affective disorders. Because serotonin here's a very good example. Because serotonin function modulates the development of brain systems involved in the emotional and stress-related responses, interference with serotonin function may modify these brain circuits. These modifications were shown to predispose carriers of genotype of serotonin, which presents an S alleles 5-TT LPR, to maladaptive stress responses and emotional disorders. Precipitating factors. Women are more prone to develop bulimia nervosa, and these may be the result of higher socio-cultural pressures to be thin. Though many other factors, for example, higher body mass index, exposure to the thin ideal promoted by the media, peer pressure culture, purist focus activities, for example, career and ballet, have been proposed to be predisposing factors according to a review of cross-sectional studies. Because of the methodological issues with the empirical evidence, the only factors that could be assessed as strongly influencing the onset of bulimia nervosa were childhood obesity between the age of 4 and 10 years old, having suffered sexual abuse or physical neglect any time between the age of 7 and 18 years old, having presented negative self-evaluation between the age of 13 and roughly 16 and a half, having dieted between the age of 13 and 16 and a half years old, having had alcoholic, obese, and neglecting parents between the age of 13 and 16 and a half, having experienced high expectations and critical comments about weight from parents between the age of 13 and 16 and a half, and having experienced adverse family events between the age of 13 and 16 and a half. Precipitating factors: dieting and weight loss. In many cases, engaging in dieting sets off the binging compensatory episodes and precedes or accentuates some psychological and cognitive disturbances. Therefore, dieting is considered to be the precipitating factor for onset of binge eating and compensating behaviors in bulimia nervosa, even when it does not lead to weight loss. It is possible that anything that has the potential to result in weight loss, unwanted weight loss, or deliberate weight loss may allow the eating disorder genes to express their potential. Perpetuating factors. There are several factors that have been proposed to facilitate maintenance of bulimia nervosa. First, there is the impact of poor nutrition on the brain function. There is research that shows that access to sugary foods and ingestion of these sugary foods changes functioning of endogenous opioids. This can result in food cravings, which in turn lead to ingestion of more of that food. Both the sensual and the feeling properties of eating give the bulimia nervosa sufferer an euphoric state, reinforcing future cravings for those sugary foods. Second and third, there are possible cognitive and psychological disturbances that result from or are exacerbated by binging compensating behaviors. Cognitive disturbances. Examples of possible cognitive disturbances are impulsivity, being locked in an allocentric reference frame, poor problem solving and set shifting, weak central coherence or only poor global integration, poor recall accuracy, and impaired information processing abilities. Psychological disturbances. Some examples of these would be emotional dysfunction, social impairment, perfectionism, a fat body weight self-schema, fewer positive, more negative and highly interrelated self-schemas, negative effect, low life satisfaction, low self-esteem, intense weight and shape preoccupation. Co-occurrent psychiatric disorders. Bulimia nervosa usually co-occurs with other psychiatric disorders like major depressive disorder. About 63% of the patients with bulimia nervosa also present major depressive disorder. One or more anxiety disorders. About 68% of those that have bulimia nervosa also present one or more anxiety disorders. Cluster B personality disorders, for example, histrionic personality disorder. Substance use disorder, at least 30% of the sufferers of bulimia nervosa meet lifetime criteria. Also, around 70% of the individuals that present bulimia nervosa engage in self-harm and present elevated risk of mortality and suicide, with lifetime suicide attempts sadly posed to reach between 11 and 40%. Presence of comorbid psychiatric disorders associated with poor outcome of bulimia nervosa treatment. Together with individual and societal costs, together with the considerable medical cost of the eating disorder and of the associated condition, there may be considerable unemployment and organizational costs resulting from productivity loss. It has been estimated in 2002 that a basic 12-week of specialized inpatient NHS treatment reached £25,000. Considering the potential physical, psychological, social and economic impairments caused by bulimia nervosa to the individual and the direct and indirect costs of the disorder on society and economy, effective treatment of bulimia nervosa should represent a major personal, medical, social and governmental priority. Treatment of bulimia nervosa, extended cognitive behavioral therapy. Though there is limited empirical evidence on treatment for adolescents with bulimia nervosa, the most effective type of treatment for bulimia nervosa in adults is a form of cognitive behavioral therapy that directly targets reduction in eating disorder psychopathology. CBT for bulimia nervosa was first designed as a theory-driven intervention to treat bulimia nervosa in the 80s. Since then, the theory consistently received empirical support. By the 90s, the intervention proved to be the most effective one available. However, considering that nearly half of the patients were not benefiting of the strategies, the model evolved to a more complex version named Extended Cognitive Behavioral Therapy. Extended Cognitive Behavioral Therapy focuses primarily on the processes perpetuating the eating disorder psychopathology, and it places emphasis on the use of behavior change as a means to modifying cognition rather than on cognitive restructuring. Currently, there are two forms of extended cognitive behavioral therapy: focused extended behavioral therapy, focused cognitive behavioral therapy, the extended version, which only targets the core eating disorder psychopathology, representing the default form of treatment, and a broader form of extended cognitive behavioral therapy that tackles additional areas. The broader version of the extended cognitive behavioral therapy was designed in order to address the needs of some subcategories of bulimia nervosa sufferers, the so-called complex cases, who, in addition to the core eating disorder psychopathology, present one or more of the following three features: low self-esteem, clinical perfectionism, and interpersonal difficulties. The extended CBT has been adapted for treatment for younger patients and inpatients and day patients. The vicious circle of binge eating according to extended cognitive behavioral therapy. According to the extended CBT, the vicious circle of binge purge can be explained by cognitive, behavioral, and emotional factors. The cycle possibly starts off with one engaging in dichotomous thinking and overemphasizing one's weight and shape. In order to achieve a lower weight or a more attractive shape, these thinking patterns are translated into behavioral strategies through food rules and or restrictive dieting. As mental and behavioral restrictions lead to hunger, sense of deprivation, and negative effect, and because the normal response to hunger, sense of deprivation, and for some negative effect result in binge eating, sooner or later one is likely to end up binge eating. One's emotional response to the perceived sin is anxiety, guilt, shame, disgust, and anger. In order to get rid of the calories that can result in unwanted weight gain and to escape the negative emotional state, one engages in compensatory behaviors. The entire chain of events makes the bulimia nervosa sufferer experience shame, self-loathing, and self-disgust. This can lead to body checking in order to ensure that the binging did not have an effect on one's body fat deposits, or complete avoidance to see one's body, and to the promise that to oneself that he or she will try even harder to achieve the desired body weight shape by not giving in again to the urge to binge it. The aims of the extended cognitive behavioral therapy. In addition, life events can directly make one to experience negative effect, even in the absence of dieting. As presented above, negative effect can result in binge eating. Knowledge that in the absence of acute starvation one presents disturbed cognition and behaviors enables the medical staff to target these disturbances directly. The main aim of CBT is to stop the binge compensatory cycle. It does this by providing the patient with information about the extended cognitive behavioral therapy, by establishing a structured pattern of eating, and by reintroducing in the patient's diet previously avoided foods. These strategies impede excessive hunger, deprivation, and negative effect about food and eating to be experienced. In turn, when hunger, deprivation, and negative effect about food and eating are reduced, frequency of binge eating is also expected to decrease. Another main of the extended cognitive behavioral therapy is to equip the bulimia nervosa sufferer with the ability to cope with events that trigger intense affect, usually negative, which directly, in the absence of dieting, can create the urge to binge eat. This is done through helping the patient develop problem-solving skills and skills to accept or alter powerful emotions. For example, patients are taught to surf the urge to binge, or to engage in alternative activities when experiencing the urge to eat, for example, going for a walk or taking a shower. The effectiveness of extended cognitive behavioral therapy. According to 3 meta-analyses, cognitive behavioral therapy for bulimia nervosa is a primary treatment for bulimia nervosa in adults. Usage of the original version of cognitive behavioral therapy resulted in less than half of the treated patients making a complete and lasting recovery, as mentioned before. Others reported that at least 75% of those who completed the treatment showed a reduction in binging and compensatory behaviors and presented in improvement in body image. The enhanced version of the treatment, extended cognitive behavioral therapy, seems to be more effective, with around 60% of those of the less complex cases and of the complex cases treated with the extended version of cognitive behavioral therapy reported full remission at both the end of treatment and at 60-week follow-up. It has been shown that the broad version of the extended cognitive behavioral therapy is more effective for complex cases, whereas the focused version of the extended cognitive behavioral therapy is more effective in the normal cases. A study showed that the broader version of the extended cognitive behavioral therapy leads to a further 20% of those classified as complex cases to recover and maintain the recovery, as compared to those classified as complex cases who received focused extended cognitive behavioral therapy. Future forms of treatment for bulimia nervosa: personal development. The imminent question is, if the best available form of treatment cannot help around 40% of those who have access to it, how can these people be helped? A qualitative study found that some women who recovered from bulimia nervosa considered the available treatment for bulimia nervosa, which very likely included both cognitive behavioral therapy for bulimia nervosa and or the extended version of this treatment, to be poor or even detrimental. Rather than relying on empirically validated treatment, some of these women recovered through self-determination when they realized that they can be more than the self-centered bulimia nervosa sufferers and felt ready to become their real self. The idea that one can recover from an eating disorder when finding something more meaningful in life to focus on than their weight and shape is supported by other studies. For example, some pregnant women were shown to recover and sustain the recovery after giving birth. Also, other studies found that the 73 bulimia nervosa outpatients that took part in the study presented significantly reduced sense of coherence in comparison with the control group. Sense of coherence is a concept measured through a tripartite scale, one of which assesses meaningfulness, that is, the extent to which life is worth living. Also, the idea that one can recover when becoming their real self is supported by research in self-actualization. A study by Clearly and Crafty found that lower self-actualization predicted higher frequency of binge eating episodes. These findings were corroborated by other research who showed that, compared to a healthy group, bulimia nervosa patients perceived their parents to be significantly less encouraging of their personal growth. Presence of meaning in life appears to be a necessary predecessor of self-actualization. Actually, according to Maslow, those who reach self-actualization do so because they firstly discover a goal in life that is of personal high importance and priority, and secondly strive to achieve this aim by consistently perfecting their unique abilities. my research, urge to eat when experiencing negative effect and presence of meaning in life. Presence of meaning in life represents one's subjective appraisal of one's place in the world. It results from understanding what one is living for, and finding meaning in life implies identifying one's innate qualities and abilities and the action steps that one needs to take in order to use these attitudes in the service of one or more people or causes. I forgot to write in here, but urge to eat when experiencing negative effect has been shown to be the precursor for binge eating, emotional eating, and overeating. In one of my research studies, a regression analysis revealed that lower presence of meaning in life and higher body mass index were significant predictors of urge to eat when experiencing negative effect, with BMI accounting for 14% and presence of meaning in life explaining a further 8.9% of the variance in the urge to eat when experiencing negative effect. Presence of meaning in life emerged as the second strongest predictor of the urge to eat when experiencing negative effect. Their inverse relation suggested that individuals who reported higher presence of meaning in life experienced less frequent urge to eat when feeling negative effect. This poses that potentially enhancement in presence of meaning in life could lead to reduction in the urge to eat when experiencing negative effect. Diminished urge to eat when experiencing negative effect may reduce the frequency of binge eating episodes. CBT for bulimia nervosa versus personal development. Though the extended version of cognitive behavioral therapy attempts to enhance the patient's self-complexity through, for example, helping him or her develop previously ignored spheres of their selves, it does not emphasize the importance of self-actualization sufficiently. Considering the success rate of the currently existing intervention for treatment of bulimia nervosa and the fact that there is some evidence that some women may experience reduction in bulimia nervosa symptomatology in the absence of CBT through enhancement of meaning in life and self-actualization, future research should explore whether information about the importance of and the means to achieve meaning in life and self-actualization can help some people recover from bulimia nervosa. This information could be delivered through independent programs or as part of one or more extended cognitive behavioral therapy sessions. Patients presenting clinical perfectionism should be carefully introduced to the concept of self-growth, being persistently encouraged to focus on areas that bring fulfillment from meaningfulness rather than through monetary or other external achievements. And these are the references.